Good evening, everybody. This is Dr. Angela DeRosa. I just wanted to first off, foremost, thank everybody who's attending this webinar tonight. I always appreciate it after a long day of clinical practice, the opportunity for all of you to jump on. I know most of us have busy lives, so I appreciate your time tonight. We have a pretty full agenda. I'm going to kind of walk you through the discussion that we have prepared for you tonight, but then please know at the very end of this, the lecture should take about 30 minutes. We will then have plenty of time afterwards to do a Q&A and get many folks' questions answered, which I know personally is very valuable to me. So if you have any questions that you want us to address, you can send them through the chat mechanism, and we will do our best to get everybody's questions answered before the night is over. And if we somehow miss some tonight, we'll make sure that we reach back in another mechanism to do so. So as an introduction, many of you may not know who I am. I'm Dr. Angela DeRosa, and I'm an internal medicine physician, but I did a fellowship in women's health and have pretty much dedicated the last 25 years of my career to women's health, and in particular focusing in on hormonal health and how it not only helps with symptom relief for patients, but also its impact on chronic diseases. As an internist, it was very important to figure that out. Why I embarked upon this journey is really important, and hopefully you understanding why I'm doing this and why I've dedicated my career so specifically to this is I experienced menopause at 35, and I really actually started having symptoms when I was in my mid-20s, attending medical school and then subsequently residency. But I was having all kinds of symptoms from hot flashes, night sweats, insomnia, even to the point where I was pre-syncopal working out because of palpitations and PVCs. And it was actually quite debilitating for me at the time. And unfortunately, nobody could help me understand what was happening to me. And at that point, it took probably 7 years of my life in understanding and research to really figure out during medical school and residency, I was in perimenopause and all the subsequent hormonal imbalances of that, and then full menopause at 35. So unfortunately, medicine tremendously failed me personally. So it became my personal and professional career goals to basically change the paradigm of that. So I've really been largely studying women's health, hormonal replacement for both men and women, but my career has been dedicated to this. It's also important to note that I did develop a clinical practice with 3 locations, 55 employees, and we treated over 10,000 patients in hormonal practice. And that was really the foundation of my clinical career. And then a year ago, I sold that practice to a larger organization to infuse capital into the organization, but then also to take the logical next step for me, which was to develop the Hormonal Health Institute, which is all about instructing other medical professionals across the country about hormone replacement therapies, and more importantly, for those who would be a consultant for folks who want to incorporate those methodologies into their practices and really be a concierge hand-holding service to help folks do that. And we'll talk a little bit about that toward the end of this and how you can potentially have those things happen and rather quickly. But unfortunately, the current teaching mechanisms out there for instituting hormonal therapies into practices are either limited, cost prohibitive, or various other things. So I am on a mission, and I hope you will join me on that mission, as it sounds like many of you are already doing so, but hopefully I can give you some additional information tonight as well. So let me get this going here. So how to implement hormone therapy, pellet therapy in particular, in 30 days, your 2019 resolution to get started. So the agenda tonight is really, I'm going to review common myths and perceptions regarding hormones and pellets, the advantages to bioidentical hormone, picking the right compounding pharmacy, why proper training is important, choosing the right resources, and then really how can you consider getting started in 30 days and the reasons to get started. And then at the very end, for all of you who are attending live, we're going to be providing you a revenue opportunity worksheet, so you can also look at the financial impacts of this as well. So first and foremost, as of any problem, we always have to admit that there is a problem. And there are so many myths and misperceptions that are preventing clinical folks from implementing pellet programs. Some are clinical, some are operational. Many are really just a lack of resources. So I want to go through and dispel some of the myths together, and let's just figure out how we can move forward. So safety always comes first. When you look at what really propagated a lot of the myths and mysteries around hormone therapy, Many of you are acutely aware, as I know I was, the Women's Health Initiative study. And in 2002, this media blast came out after the Women's Health study was abruptly stopped due to this main media message that went out and said, holy smokes, hormone therapy resulted in a 26% increase in breast cancer risk and a 29% increase in heart disease. I can tell you, I know that scared the heck out of the majority of my patients at the time, and patients came off of their hormone therapies in droves. Clinicians were afraid to prescribe hormones, and unfortunately, the effects of that one single media plug pretty much has irreparably harmed women's health for decades to come. And it's really unfortunate, and it's interesting that even the International Menopause Society and a group of their investigators went on to sue the Women's Health Initiative to basically say exactly that they have now caused so much harm toward women's health because of a mishandling of this information. And as just a current reminder, and we're going to go through this quickly because I know a lot of you are very acutely aware of this study, but I wanted to give some background as we move forward on some of this discussion. But the National Institute of Health wanted to study the effects of hormone, and primarily on cardiovascular disease and breast cancer, and spent over $700 million to do so. It was a lot of money, a lot of time. They enrolled 16,000 women with a uterus, 10,000 women who had a hysterectomy, and put them on Prempro or Premarin respectively for each one of those study arms. To reduce the expense and the time they enrolled, because you can imagine this was a massive undertaking, they enrolled women up to the age of 79. And unfortunately, 2/3 of the women in the trial were over the age of 60, which clearly were not the women that typically are going through the menopausal years and having those perimenopause and menopausal events that are so troubling to our patients. And as you are aware, the trial was stopped abruptly due to concerns about breast cancer and increased cardiovascular risk. And to review kind of the information, and what was so alarming is that they said it was a 26% increase in breast cancer, but when you actually looked at the absolute numbers, it was really only 8 women more per 10,000 women. And the cardiovascular was also 7 more, the VTE 18, and stroke 8. So when you actually look at the absolute numbers, they're quite minimal by comparison, but that wasn't the only problem. Another thing that happened is when they first originally put the study out, they used a 90% confidence interval, which is absurd, and nobody in science uses a 90% confidence interval. It's always 95%. So when they actually corrected the data and they actually delved into it quickly, they actually realized that the Prempro arm, the Premarin Provera, had a reduced risk of breast cancer, and then the cardiovascular risk in the women 50 to 59 was also a reduction in risk. So nobody actually went out in the media and corrected that, and a lot of these misnomers carried forward. And then when you looked at the original Premarin arm, which I always thought was interesting, is they never ever discussed that the breast cancer risk in that Premarin arm alone from the very get-go showed a reduction in breast cancer. And it was actually insufficient evidence for coronary heart disease. So once again, the media took the ugly parts of the study and didn't even propagate the positive messages that could have been out there and totally skewed this based on fear. And then when the revised WHI findings came out, again, you can see that the reduced risk stayed forward in the breast cancer, and the women with coronary heart disease showed a reduction if they were between the ages of 50 and 59. So what did the WHI actually find? That number one, neutral risk of breast cancer in the Prempro arm, a decreased risk of breast cancer in the Premarin arm, a decreased risk of coronary vascular disease in women 50 to 59 in both arms, and that women 10 years from the menopausal time frame greatly benefited from HRT. And then if we're going to prescribe hormones in women that are older, over the age of 60 with coronary vascular disease, we should be using caution, which makes perfect clinical sense to me. So the media, unfortunately, pandered to women's greatest fears, the fear of breast cancer, to ensure that the word of the study would spread like wildfire. And unfortunately, as all of you are aware, it's ensured that the conversation would be driven much, much more by emotion and politics than by pure science. So for all of you, it's really important that you get out and look at this particular paper. It's really an evidence base for HRT and what can we believe. It was put out last year in 2017, or excuse me, at the end of 2017. And it really walks clinicians through what actually really happened, why the investigators who were actually involved in the study were completely blindsided by what JAMA put out, and all the different misnomers and myths. So if you haven't gotten to read this study, anyone who's doing menopausal or hormonal medicine, it would really be important that they do so. But the good news in some of this, in the last year or two, the pendulum is starting to swing in this regard of the fear. And that IMS, the International Menopause Society, came out with a global consensus statement. Even NAMS, who has been largely unsupportive of hormones, is starting to soften their viewpoints. And there's a lot of data that's coming out, or at least articles that are really swinging, showing that, yes, in the right patient population, hormones may be beneficial. So our work isn't done, but it's certainly going in the right direction right now. So another myth, the myth that keeps clinicians from prescribing hormones, in particular pellets. They say with pellets or certain products of hormones that they're not FDA approved. Well, what's really interesting is the FDA, for those of you, actually approved Testapel, which is a 75 milligram testosterone pellet. But yet they seem to have issue with compounded pellets and other dosing and other compounded products. But people ask me all the time, well, why don't they approve bioidentical hormones? Well, unfortunately, bioidentical hormones are like a hamburger. You can't patent a hamburger. There's nothing unique or special about it. You need to have a special delivery matrix or something that makes that product particularly unique, either synthetic chemical compound change, a delivery mechanism, or something in order for a company to actually spend the money to launch a product so that they can get it FDA approved. If I were to take a compounded, let's say 76 or 80 milligram pellet to the FDA, or brought it to the FDA, I could probably get that approved with the data that's out there, but I would have no ability to protect it from a patent standpoint because there's nothing unique about it. So unfortunately, everybody could copy it. And Testapel learned that the hard way because although they compounded it and patented a 75 milligram pellet, as you know, a lot of the compounding pharmacies now created a 70, an 80, a 62.5. There's all these things right around it. So there's no, you would lose a ton of money to bring something to the FDA and get it patented and approved. And companies are not going to make that mistake again. The other thing is also there's a lot of lobbyists working against the compounding and anti-aging market. And I always say follow the money, follow Big Pharma and the power that Big Pharma has, and don't underestimate it, because when I worked at Procter & Gamble for 8 years as a senior medical director, I saw firsthand some of the things that went in against working against the wellness of patients, as well as the companies that were trying to be on the anti-aging side. So another problem that I see when we talk about hormone therapies is that there's this huge mystery around the pellet insertions themselves, that you're going to need a lot of surgical expertise or training to actually put the pellets in. Honestly, the hardest part is actually understanding how to best manage patients medically. The surgical insertion technique is actually a very simple in-office procedure. And frankly, I can do a female patient insertion in about 1 to 2 minutes, and a men may take about 5 minutes. It's meant to feel like it's more complicated than it is. And actually, in the right states, under the right scenarios, nurses, medical assistants, and depending on the regulations in those states, can get away with doing those insertions. However, it's important that usually the clinicians are the ones that are doing those. But you really need the right training. And the most important part of that procedure is not only sterility, but ensuring the proper placement. The actual insertion itself is actually very, very easy. The other thing that we have to look at is to make sure that we're putting the pellets in the right candidates. And for those of you who realize the no-acetol syndrome, the patients that have a really flat butt, in particular the men and the male insertions, are not good candidates. So really understanding who is not the right person to put these pellets in as well, so they don't have bad outcomes. But the techniques themselves are very, very easy to teach and can be taught very, very quickly. Another area that becomes of concern and pushback is commitments. And once the pellets are in, that you can't take them out or make changes. Under very rare circumstances, they can be removed, but it's not easy, practical, or recommended, which is really important that you have proper training and resources. But again, you really need to understand who the appropriate patients are. If you have a need for quick reversal, say the patient is considering pregnancy within the next year, you may not want to put those in those patients. Also, the worried, anxious patients, not ready, or those that are really difficult, kind of psychosomatic, those are, no matter what you do, they're never going to be happy. They will create more anxiety for those patients if they're not willing and ready to proceed with the pellet route. So sometimes saying no and not forcing the issue is also much, much more important. And while also some patients, they are willing not to take any risk in any way or form, those are not the good candidates for pellet therapies. And you also need to make sure that the patients are properly informed so that they understand what the procedure involves, the ongoing commitment with that, as well as understanding that there can be some side effects while we're obtaining the proper dosing, and giving them all the choices of what's available. But what I have found, and where patients get into most trouble, and also clinicians who write and prescribe for pellet therapies, is that oftentimes the most common side effect, and the one that makes patients skittish, is actually estrogen excess. And the problem is that the burn-off rates of testosterone versus estrogen pellets are going to be very, very different. As females have significantly more adipose than their male counterparts, that they are going to need much less estrogen, because estrogen is savvy. It saves itself for a rainy day. It actually stores itself in the adipose tissue, and if you flood the body with too much estrogen and it oversaturates that storage capacity, you are going to develop estrogen excess symptoms, as well as patients who have not seen estrogen in a long time. So if a woman is 10 years postmenopausal, they're going to have a harder time taking in all that estrogen as, say, someone who's immediately menopausal or perimenopausal and has a higher need for estrogen. So if you are going to be aggressive or more assertive with a hormone, testosterone is much safer because we don't save it. We burn it off quickly compared to estrogen. So when I'm teaching folks about pellet insertions, always go much, much more conservative with estrogen, and be much more readily assertive with testosterone. So when you're placing these, again, when you're dealing with the commitment of pellets, you're always better off to put too little and then add back at another time than putting in too much and then potentially getting in trouble. The other thing that we have to take in consideration too is the first time is always going to be different than subsequent times. If the body is significantly depleted of hormones, it's like when you give that patient a hormone replacement, in particular with pellets, it's like giving a starving man a meal. So that patient is going to eat up that pellet much faster the first time compared to subsequent times. So I see providers make the mistake all the time of putting in a pellet and then saying, come back in 6 months and you'll get your next one. Well, the subsequent times that may be okay. Frankly, that's actually too long for pellet insertions. They should actually be around 4 months. But with that said, the first time you put them in, if you don't give a quick boost shortly thereafter, or 1 month or 2 months to fill the gas tank, you'll be starting over each and every single time with the dosing. So you need to fill the gas tank the first couple times, and then you can get longer burn rates. So it's, when you talk about the commitment of these pellets, you need to understand the physiology and the pharmacology of these so that you can properly dose these and not get yourself into trouble. And then it's also very, very important to educate your patient that if something were to go awry and they do have some side effects, that they should notify you and not just struggle through them, and that there are ways to manage them. And as I mentioned, the good news with testosterone, if we go too high, usually they're only too high for a short period of time, especially that first time, and it may only be a week. Where if you get into trouble, it's usually because you gave too much estrogen, and unfortunately that can linger a long time. But in the right patient, and very, very rarely, you can block them down medically with Proscar for testosterone, Femara for estrogen, even in females. But the goal is to do that when it's extremely extreme of an outcome. And frankly, in the 25 years that I've been practicing this area of medicine, I've only had to do that less than 5 times. So it's not a common occurrence. But again, it's knowing how the hormones work and avoiding those commitment problems. So Blue Horseshoe loves Anacott steel. I don't know how many of you out there are Wall Street fans, but it's one of my favorite movies. But it leads me to the thought, another thing that people get concerned about is the cost of pellets compared to other options. And when you actually look at the annualized cost, it's close to being equivalent to other types of delivery mechanisms. So although in our at least region of the country, pellet insertions for women go about $300 an insertion. The males are about $700 an insertion. And typically when you look at patients in my area and how I train, we usually do them about 3 times a year. For the first year, it may be 4 times because of that filling the gas tank phenomenon. But when you actually start to look at the monthly cost of troches, creams, and various other delivery mechanisms, it's not that much more when you have to annualize the cost of the pellets. So to get that much better outcome, it's actually much, for a couple $100 difference for most patients, that's going to be very, very valuable. Also, when they have better outcomes, they're going to have less indirect side effects. And then when also people think about costs for the provider to do a training or implementation program, they're missing an opportunity from revenue standpoint by not providing pellet therapy, and also just the indirect success of hormones, because it's such more rewarding. And also during the training period in the right training phenomenons, you can actually recoup quickly the cost to implementing those types of programs, given the fact that it is a cash revenue opportunity for most practices. So the other thing, and I get frustrated when I hear this and they say, pellets, are they good enough? And I've heard many fallacies about pellets over the years, and most recently, actually coming off the A4M meeting, I was doing some competitive analysis on different pellet training companies, given the fact that I'm in that space. And one very highly respected and one well-known physician in the anti-aging field actually on an email stated back to me, and this is what I quote. They said, "We do not provide pellet therapy as we have found in the past that pellets do not offer the same consistency in releasing of the hormones as creams, injections, or oral pills and tablets do. We also have found that do not make them available to change the patient's dose, which is usually critical in women undergoing HRT." And I was so angry when I heard this, because nothing could be further from the truth when you actually break it down. And again, when I was at Procter & Gamble, I had the luxury of understanding pharmacokinetics and physiology of multiple types of hormone methodologies. And when you actually start to look at it, pellets really are the gold standard. But let's review kind of the differences between the different types. And when you look at bioidentical hormones in the creams and troches, although they can work fairly decently for some patients, and I say on average you'll get about 40% relief of symptoms, a lot of that's due to the up and down peaks and troughs that occur daily from taking those. Because when you take it in the morning, you're going to spike by mid-afternoon, and then it's going to come back down. So you either are half of the time, or excuse me, a third of the time above therapeutic levels, which can lead to more side effects of those patients, and only a small part of the day in a therapeutic range, and then the other third, you're in a deficient point of time. So you're going to get more variability, more side effects, and also lack of effective relief. So it's not ideal. And then when you look at patches, you can often see that the patients really get this variable rate of dissolution, but actually this is what's put out in a lot of journals about the pharmacokinetics of patch delivery. But actually what I've found in practice is that the patients are actually chasing doses, because within the first 24 hours, they typically get almost 90% of the dose, and it's the last 2 to 3 days that it's almost negligible. So they have a great relief of symptoms day 1, and then day 2 and 3, they're suffering. So they start putting patches on daily, and they're chasing, quote unquote, the high. So although patches can work for some patients, they're also not ideal. Why I'm a huge fan of the pellets, and why when you look at the breakdown and the absorption of pellets, they are the only formulation that can deliver a very consistent baseline within a therapeutic range once you identify that range for the particular patient. You will avoid the spiking, which can lead to side effects, and then you will also have best symptom relief so that the patients don't get deficient. A caveat to that is if you extend the pellets out to intervals between pellets too long, you are going to drop into that deficient low therapeutic level. So oftentimes when you look at pellets, I see practitioners doing them twice a year. That may actually work with estrogen because of the storing in the adipose tissue, but the pharmacokinetics of testosterone will not stretch to 6 months. So you will often get a rebound of the testosterone deficiency symptoms much, much sooner. So you really need to be cautious if you're going to do pellet insertions Q6 months versus, say, on average 3 to 4 for women and 4 to 5 for men. So the other advantages I see with pellets is that it avoids the first pass liver effect, which avoids the clotting factor release and the release of SHBG, which can bind other free hormones. Patient compliance goes up dramatically. I kind of always joke with my patients, it's kind of like Ronco chicken. It's like set it and forget it. You don't have to worry about remembering to take it, and you get very easy compliance for the patients. And also because of that ability to put patients into those baseline therapeutic levels on a consistent basis, you're going to get the most effective relief of symptoms and blood parameters, which can also lead to improvements in insulin resistance, bone health, and various other things which are important from a chronic illness management. And the other thing is they're long lasting. So patients, as I mentioned, can go 3 to 4 months without having to have their pellets insertion for females and 4 to 5 typically for men. The other thing that's really important is to understand when you're purchasing these pellets that you have the right compounding pharmacy. And over the last decade, I have played around with different pharmacies and ended up with some that weren't so great and others that were awesome. And then there were some that I just got variable responses from my patients. You really need to make sure that you have good quality of control and assurance that what you're getting is what you're buying and what they say that they're providing. Also, understanding that autoclaved and heat fused pellets are going to respond and absorb much differently than those that are not. So understanding how those little tiny nuances can dramatically affect not only the extrusion rates, but also how well the patients respond from an absorption of those hormones. I'll skip over the 503A versus 503B, and I'll address that on the next slide, but that's a very important status that we need to understand. You want to make sure that they're specialized in offering in hormones, and it's not just a small part of their offering, and that it's really an area of expertise within that compounding pharmacy. And obviously, customer service is always important. I want to know that I can easily order them quickly. I have great service associated with my ordering process, and that obviously we want to make sure they're cost competitive. And keep in mind that the cheapest isn't always the best. So it's really about finding the most cost competitive within the quality pharmacies that offer hormone therapies and pellets in particular. And to address the 503A and 503B, I know a lot of people talk about that, but they may not have a full understanding. But it's important that when you're using pellets in your practice, that the facility you're buying pellets from are a 503B. Because the difference is the 503A is sterile medications must be dispensed as patient specific. Each patient needs a specific prescription written for that. In the 503B, it does not have to be specific. You can order pellets in bulk that you can then distribute in your practice. It doesn't have to be set aside for any one individual patient. The 503A does not need to follow the CGMP guidelines and compliance, whereas the 503B do. They have to have good manufacturing practice and compliance, and trust me, the FDA is watching them very, very closely. And the 503A has to register with each state board of pharmacy and DEA, but also on the 503B, they have to register with both the DEA and FDA, but also report product lists to the FDA biannually, and they're under much, much more regulation. At the bottom of the slide, there's a link there that was a really excellent article written by the Wells Vice President of Quality Assurance. So I encourage several of you to take a look at that, and if you want to get more in depth on that. So the number one reason why a lot of clinicians don't do pellets or get involved in pellet therapy is they don't know how to get started. And there's so many things that go into figuring this out. And oftentimes you go to these conferences and you think it's a great idea, but you walk away from, say, an A4M or another mini weekend course and you're going, okay, that was great. I really want to do this. I got a lot of awesome information, but I don't even know where to start or how to get going. sometimes the clinical piece is really easy and you go, yeah, I get that. That makes total sense. But how do I operationalize it? So this number one concern of how do you get started? How do you pick the right patients? People are always concerned, how do you interpret the labs? How do you dose the pellets? Frankly, dosing pellets is simple once you understand how to interpret the labs and how to interpret the data, which is actually not that hard once you have someone walk you through it. The pellet insertion procedure, I mean, you can go to a weekend course, but if you're not doing a few of them in a row with some oversight in your own office, that can be intimidating for some people. How do you manage complications that are inevitably going to occur, and who's going to be there for a resource? How do you price it? How do you even compete in the marketplace? And then how do you go out and market to your current patient database or get new patients externally? And I think one of the most number one concern is, how do you operationalize this? How do I get my organization to absorb this, take it in, and go through all the steps so that I can do it properly, compliantly, and in a manner that makes sense within my own practice? And if any of you have not read this book, Blink, it's a fantastic book by Malcolm Gladwell. But they always talk about needing 10,000 hours to become an expert in something. And since I was 28 years old and finished my residency, and I'm now 51, I can tell you I've had over 10,000 hours to become an expert in this field and studied this exclusively. But you all don't need to have 10,000 hours. What you need is access to 10,000 hours and those resources. And for me, it's always about surrounding yourself with people that are much smarter than myself. And trust me, I've got a whole boatload of people that I've surrounded myself over the years who I've learned a tremendous amount from. So know that you can do this with the right resources if you don't have the 10,000 hours. Not feeling the love, though, when you talk about training options, they've largely been limited and marked with problems. A lot of them are either restrictive or costly. I am aware of certain organizations where they'll take $100 per your pellet insertion that you're offering as part of the contract that you get involved with affiliating with them. Or they have pellet dosing calculators. And to me, that's irresponsible as a medical clinician, somebody who's clinically managing patients, to not understand why they're picking the doses, to put a dose into, or put patient demographics into a calculator and have it spit out and give you a dose. That may be an easy way to do it, but it's not the most scientific and clinically responsible way. You need to understand why the doses are going in, because if there's a problem with that calculator, you're not going to know. Weekend training, so a lot of folks are going to these weekend courses and they walk out and they go, well, that was great, but now what? Or if you get involved with franchises, it can be costly and you're being held accountable to somebody else, but most often a lack of ongoing support. So really having somebody you can call or text or on a moment's notice if you have questions or difficult patients, having that information as you work through this, because inevitably once you get started, it may be easy to start, but it's all the stuff that comes up afterwards, weeks, days, months afterwards that you really didn't anticipate. And then also having operational support. A lot of these training programs, they don't have operational support. Do you have the right consents? Do you have the templates to plug into your EMR? Do you have the policies and procedures, inventory controls? How do you stay out of legal trouble? So those are the things that are really important. So one of the things in creating the Hormonal Health Institute and coming forward, this is going to kind of be my plug for what I like to do, and I'd love to train and educate. But the Hormonal Health Institute is really a concierge handholding where the training comes to you in your office with your patients, providing you step-by-step implementation and support from operations, clinical documentation, avoiding legal and board problems with proper consenting, templates, also not having any purchasing requirements. This is your practice. You need the information and you need to be able to gather all the income and revenues from what you're doing and not be passing that or giving it to somebody else. There's no franchising fees. You maintain your autonomy, and you also don't have to deal with these mysterious calculators. You learn how to properly dose. And what I personally offer is not a weekend course, but a year-long support or questions, resources, and problem solving. And if folks want it, we can also develop marketing, website development, and PR support. And just to give you an idea of how fast you can implement under this kind of institute, is I just did this for a client in January, but you could be on a phone doing a practice assessment on a one day, getting agreement signed on the next day, followed up with organizational calls. I work with you on getting your vendor set up. I help you order your supplies based on your anticipated volumes. We get the operational documents in place where you have templates, consents, everything you need to get ready to go. And then it takes time to get everything in and organized. And then we do a full didactic day of training where I teach you everything about hormones, anything from basic hormones all the way up to pellets and how to insert them. And then coming to your office with your patients in your location, doing live patient training for a day or two. We can do it longer based on certain packages, but to really see patients with you so you can understand it and have a feel for it within your own patients. And to me, that becomes much more, it imprints much deeper because you're dealing with the people that you interact with versus some random cases on a screen that make no ability to have sense with you. But also, when you think about doing something like this, the reason why I find such great joy in this is that you really do truly affect patients' lives. They're healthier, they live better, you have a healthier, happier patient base. It's highly rewarding when clients and their husbands and wives come in and say, oh my gosh, I've got my wife back, I got my husband back, my children are happier, we are happier. In the day and age where physician burnout and provider burnout are so high, trust me, to have that kind of joyful interaction with your patient versus the chronic march toward death with chronic illness in the traditional practices, this is so much more satisfying. And the really nice indirect thing, as always, my grandmother said, do what you love, the money will follow. You will get paid to take better care of your patients for doing the right thing medically. And when you look at what that can look like from a financial opportunity, you will all be getting this prep sheet from me that you can do your own calculations to understand what that opportunity could look like for not only being happy, but also from a financial aspect. If you go to my website, which is drhotflash.com, there's opportunities to have a free membership to get different information. But also, if you want to obtain the brochure about the consulting services I can provide and my team can provide to help you implement something like this quickly into your organization, we'd be happy to provide information or even get on the phone and talk with you about what that could look like. And we can tailor it if there's a program there that doesn't feel just right for you. But you can contact me via my email, which is HHI, Hormonal Health Institute at drhotflash.com. If you just want to learn more about our services, or if you just have some questions that you would just want a resource to talk to that's been doing this a long time. And please check out the website, drhotflash.com. We have a lot of great information on there and how we can potentially help you. But with that said, know that you can get this program up and implemented really, really quickly. Pellets are a blast to work with it's a powerful tool in your practice. And certainly I'm willing and ready to offer that assistance to any of you. And at this time, I'm going to open up for questions. I did have one come through that I'd like to address. There was a clinician had asked, I have a patient who has been on hormone pellets, and she had basically stated that she was having breakthrough bleeding despite being on permethrin or progesterone, 200 milligrams nightly, and was getting ready to have her next hormone insertion. And I'm assuming it's including testosterone, but it was alluded to that it was estrogen at 6 months. How would you advise managing? So a couple of thoughts on that. First off, whenever you're out at a 6-month interval, there's a potential that you can actually get drops in estrogen that are significant enough where it will destabilize the uterine lining, which can lead to breakthrough bleeding, in particular as you get to the end of the pellet interval. So I would definitely want to look at that and potentially shorten down those pellet intervals. But the most important thing I would want to make sure is that, number one, that I'm assuming this patient was worked up for endometrial hyperplasia or polyps or fibroids or other things, so that a transvaginal ultrasound was done and potentially an endometrial biopsy. So ensuring that we're not dealing with anything pathologic, number one. But with all those things, if we've narrowed the intervals down, we've ruled out anything problematic, there's several ways that I would consider managing it. Number one, some patients just don't, despite the fact that they're bioidentical progesterones, they don't work as well as some of the synthetics. You could switch to norethindrone, the 5 milligram half tablet QHS, although I'm not a fan of the synthetic. It stabilizes the uterine lining much stronger than the bioidentical. That is one option, not my first. The other is you could actually cycle the patient using the 200 milligram days 1 through 10. Ideally, you should be, or in an optimal world, doing that monthly. But the research shows that at least if you're doing that quarterly, that you will slough enough endometrium to prevent hyperplasia. So at least having them cycle every quarter. So that's another option. Another consideration is to stop the estrogen pellets and just use testosterone to control their symptomology, although they may lose some of the estrogen protection. Not my favorite choice. Also, if there's an opportunity to be, as we look at more aggressive choices, to potentially do a DNC followed by an ablation and then resuming progesterone at 100 milligrams nightly. And the most extreme would be to do a hysterectomy on those patients. But again, I'm not recommending, I'm just giving the opportunities from the least aggressive to the most aggressive, depending on the patient's desire. So thank you for that great question. I hope that helps. Okay. So I have another question to show the reference for the climacteric. While I'm answering other questions, I'm just going to flip back to that so that you can look at that briefly. Hold on. When I guess my, oops, let me go back. I'll go back for a second. That's the one article, and then I'll flip forward to contacting again. I'm sorry, I'm just reading through some of the questions. Okay, so a patient has no this practitioner has placed a 47-year-old male with post-testicular cancer, placed pellets in the flank region because he has no adipose in the buttocks, 2 pellets extruded. How can I avoid extrusion? So this goes back to my comment about looking for the right patients and offering them the right methodology. And although I'm always going to use pellets as usually my go-to and my gold standard, and some men, if they have no buttock fat to work with, they may not be appropriate candidates for pellets, and then injections of T-cypionate or other testosterone derivatives would be more appropriate. I have not been doing on a regular basis flank region insertions of pellets. I just find that they tend to extrude, in particular with males, given the fact that the pellet insertions are much more involved and include many more pellets than the females. And I have found that the extrusion rates are very, very high. So personally, I don't like to insert them in the flank region because of that pellet extrusion. There's not a whole lot I can do to avoid that. And there are also some males that even if they have the no acid all syndrome, that they're not appropriate candidates. One thing I have done for patients who just absolutely wanted the pellets who are males, I have split the doses. So for instance, I'm putting 10 200 milligram pellets in. I would do 5 on one side and 5 on the other buttock to kind of spread, to lessen the dose that's going into one area. So that's one possibility. But again, it can be challenging in certain patients, and sometimes it's just better to not do it from that route. So typically when you look, another question, what hormones can be delivered by means of pellets? The pellets can be with the testosterone, the estradiol, the progesterone, and then there are some that you can blend other things like anastrozole into those pellets. I'm not a fan of blending those because the burn rates of the anastrozole are going to be a little bit different than the actual testosterone itself. I am also not a fan of progesterone pellets. That's one area that I think it just doesn't work as well. I've seen more breakthrough bleeding with the progesterone. Also, when I'm looking at the risks and why I'm using progesterone, it's largely to protect the uterine lining for endometrial hyperplasia. And the data is just much more compelling and solid for the progesterone capsules, tablets, Prometrium for uterine protection. The pellets, it's possible that toward the end of the intervals that they can go below therapeutic levels, which can also lead to not enough protection at the uterine lining. So I'm not comfortable when it comes to preventing endometrial hyperplasia using progesterone pellets in those types of patients. You would just have to really monitor, if you're going to go that route, transvaginal ultrasounds at a minimum every 6 months, maybe sooner, and checking blood levels of progesterone to make sure you're getting adequate levels of progesterone in the blood. So great for testosterone and estradiol, but progesterone I will deliver in another mechanism. Okay, which one did we work on? This one's. Okay. So a question is, if clients are athletes, bodybuilders, or triathletes, will they burn through the pellets quicker? Absolutely, they will. So when you actually look at pellet dosing, again, we talk about a lot of those calculators and various things. It's not as hard as it needs to be, but there's some really nice protocols on how to dose them. Some of the things that you must take into consideration are the patient's weight, the patient's age, but the third most important parameter is really looking at how active those patients are, because a more active patient is going to burn through them quicker than a more sedentary patient. When you actually look at how the pellets absorb and burn off, I think of it, and I've heard several mentors of mine use this analogy, but I'm going to steal it from them, is kind of the pellets are like little lollipops sitting underneath the skin. And the bloodstream is really like the tongue licking the lollipop. And the faster the heart rate is going, the faster the absorption is going to occur against that surface area, like licking the lollipop of that pellet. So if you're sedentary during the day or less active and don't work out, you are going to have a burn rate that's slower than, say, someone who's largely active during the day. And then again, when you're sleeping, you'll slow the absorption versus running around during the day. So that is one of the parameters. The other thing is how they burn is really when you look at the brain chemistry. When it senses a depot of something it wants, it pulls it into the bloodstream much faster than those patients who have adequate levels. So which also leads to why they burn faster the first time you put them in versus subsequent insertions. So absolutely, with those bodybuilders or triathletes, you may have to increase the doses and shrink the intervals, or both. So that can affect the absorption rate. Another question, what do you mean by pellet does not affect clotting factor? So when you look at hormone therapy, when you take an oral hormone, so let's say I were to take Promethrium or Provera or Premarin, any of those oral hormones that you swallow and goes into the stomach has to process through the liver before it hits the bloodstream. And typically when that process happens, when it processes through the liver actually does a couple other things with that metabolism. Number one, it's going to end up kicking out SHBG, serum hormone binding globulin, which will then bind to other free hormones. So with oral derivatives, you will often have to use higher doses in order to overcome some of the free binding of the free molecule of testosterone, estrogen, and it can also bind with thyroid and various other things. But also when you swallow oral pills, when they process through the liver, it engages the clotting factor cascade, which is why you will increase your risk for blood clots, heart attack, and stroke. When you avoid the first pass liver effect of that, so through pellets, creams, gels, troches, patches, sublinguals, anything that avoids that first pass liver effect, you are not going to engage the clotting factor cascade. So the pellets do not engage that clotting factor cascade, so your risk for increasing a blood clot, heart attack, and stroke do not go up as they would with an oral formulation. Okay. A lot of great questions here. Thank you. Question, do you do training for advanced practice providers? Absolutely. They're so much fun to work with. Do you check labs at 4 weeks and prior to reinsertion at 3 to 4 months? So typically my protocol is when a patient comes in for a consult, we check baseline labs. Based on the pharmacokinetics of the absorption of pellets, it peaks at 4 weeks, so it's ideal to get an assessment of checking blood work at 4 weeks and seeing the patient back at week 5. Then the first year, I am checking blood work prior to insertion, usually about a week before insertion, just to ensure that I've got the right dose that's completely optimized for that patient and there's no safety concerns, more so with men with CBCs looking for secondary erythrocytosis, but just making sure we're getting the right consistency that first year. Once a patient is stable, then I will typically check blood work every 6 months, in particular if they're also being managed with thyroid medications, because I don't want them to go longer than a year. But that first year, I'm keeping tight control on them to not only make sure they're safe, but also to get the best, most optimal results for that patient. Let's see. So one of the questions is, what documents and registration is required to offer pellets? The only, why is this any different than offering bioidentical hormone therapies? So when you're writing scripts that go out to compounding pharmacies, those scripts go directly to the pharmacies. They typically drop ship to the patient, or the patient picks them up depending on what compounding pharmacy you're going to. And the risk is all on the compounding pharmacy for that delivery and making sure that that product is of good, solid quality. So as far as registration for pellets, when you're carrying hormone therapies in-house and you're placing them into patients, so no different than T-cypionate, testosterone pellets are actually a controlled substance. So you have to have a policy and procedure to manage controlled substances in your office. How do you properly store them? And you do not need a dispensing license because you're actually putting them in the patient in your office, so they're not leaving with them. But in some cases, if you're dispensing bioidentical hormones out of your office that leave with the patient, then you do require a dispensing license. So as far as documentation, really it's about how you're managing controlled substances within your practice. What is your protocol for insertion? So good, solid policies and procedures and compliance documents that would be within any kind of private practice or medical institution for that matter. Okay, question about pellet therapy in special conditions, breast cancer survivors, and also endometriosis. So let's start with breast cancer, as that's a very compelling topic and applies to a lot of patients. When I look at my breast cancer patients, I kind of have to figure out, are they actively undergoing treatment, or are they long-time survivors and with a remote past history of breast cancer? I'm going to break this also down basis on estrogen and testosterone. Estrogen in an estrogen-positive, progesterone-positive patient has the potential to stimulate estrogen receptor type cells, which then could potentially increase recurrence rates for breast cancers and or activation of current and growth of current breast cancer cells. So you have to be very, very cautious in the estrogen discussion of patients. If a patient is 10 years remote from having a breast cancer diagnosis, has undergone all their treatment, has had a mastectomy, in particular bilateral, there is some argument to be said that they're probably safe candidates for estrogen, in particular in a highly informed patient who has an oncologist who's very supportive, and their symptomology is so severe that their quality of life is affected dramatically, that estrogen therapy, they're practically begging you for it. In those scenarios, I may consider prescribing estrogen, although it's not my preference to do so. If they're ER negative, PR negative, there's an argument to be said that they could easily go on and have estrogen, and as long as their oncologist is supportive of moving in that direction, I am comfortable in a highly informed patient, and obviously we want to document these patients very clearly of their consent to move forward in those scenarios. Vaginal estrogen, Vagifem, estrase cream are all fine. They do not systemically absorb in those patients, so I'm comfortable for vaginal health delivering estrogen transvaginally. Now, the interesting thing is testosterone in breast cancer. And when you actually start to look at the historical use of testosterone and also the current data, we used to use testosterone to palliatively treat breast cancer patients for amelioration of symptoms and also for protection. And those patients actually did fine, and they showed over time, and there's actually really good research by Rebecca Glazer and Demetrius out of Greece, and they've done thousands of patients that show that testosterone coupled with aromatase inhibitors can decrease the recurrence rates dramatically compared to those who are not on testosterone for their breast cancer recurrence rates, and they also have much, much better outcomes from all of their other comorbidities. So when you actually look at testosterone, there's compelling evidence that it decreases apoptosis, decreases their recurrence rates, and also gives them great symptom relief of their menopausal symptoms. Excuse me, I have to drink some water for a second. So, excuse me. So over the last 25 years of doing this kind of medicine, I have actually reached out to oncologists in these scenarios, and 99% of the oncologists have all agreed with me starting testosterone, even in active breast cancer patients, as long as they're on aromatase inhibitors during the active phase of starting testosterone with their consent and full being on board with it. So testosterone in breast cancer patients is highly beneficial, may be protective, and it certainly decreases recurrent rates, and it gives them a much higher quality of life. But the caveat is always make sure you don't put the patient in the middle, clear it with their oncologist first. But I will almost assure you that unless they're highly uninformed, that they're going to agree with you going forward in that manner. And I'd be happy to send research and recommendations to support that evidence if anybody needs it. Okay, we're getting close to winding down, so let me see a couple more questions. Okay. So the question is, what testosterone blood level range do you like to have your female patients on pellet therapy and estradiol blood levels? So typically, when I look at those two, the average, so again, 80% of my patients sit really well when I'm delivering exogenous pellet therapy of testosterone between 150 and 200 nanograms per deciliter. There are some patients who sit lower than that. There are some patients who sit higher than that. But when you actually look at the pharmacology and physiology and all the various data sets over the years, it is about 2 to 3 times the normal reference range when giving exogenous testosterone that actually will lead to enough therapeutic serum levels to ameliorate patients' symptoms and give them positive benefit. So that's typically the range that I shoot for, and I know most of my colleagues in this area are pretty close to that as well. Now, estradiol blood levels are going to be a little bit different, depending on the patient, but what I have also found that estradiol by itself is completely useless. You need to couple that information with FSH so that you can understand how that particular patient is responding to the therapy. So it's really the combination of FSH and estradiol, and then using testosterone between 150 and 200. Okay, and I think we have time for one more question. Insertion techniques. Let's see, is there a package? Will the slides be available to me? Yes, absolutely. I'll make sure that those are available for patients, or excuse me, for the participants. Okay. There's lots of great questions, so I promise you I will sort through these afterwards and see if we can't get back to everybody individually. Do I know if pellet therapy is allowed in Canada? I'd have to do some research. I believe it is. I know it's in the UK and also in Australia. I would be willing to do training in Canada. Canada is a beautiful state, or excuse me, not state, country. I used to actually live in Montreal for a short period of time, but would happy to look into that. And will we be able to listen to this lecture again online? Yes, of course, we'll make sure it is available. So unfortunately, we've come to the end of our discussion tonight. I promise I will sort through all of the questions that were asked and get back answers to those to ensure that you get all the information you need. But I hope you all consider reaching out if you have any other further questions, or if I can help in any way from a training standpoint, I'd be glad to do so. But I'd like to also thank Wells and coupled with A4M for hosting me tonight, and all of the wonderful participation by everyone here this evening. So I hope you have a wonderful evening, and I look forward to hearing from some of you. Good night, everyone.